Hello doctors, welcome back to Asan Network, and I am your Dr.Salauddin, MBBS MS Orthopaedics, and welcome to our new series, that is the Voice in Ortho. So this series is about knowing why are some things happening in orthopedics. Like today's video is about why avascular necrosis occurs in fractured neck of femur. Okay, so before going into the topic, let's think in terms of an case scenario. Now, for example, a young adult who is driving a bike. Okay, a young adult who is driving a bike has a skid and fall from his bike and sustains injury to his left hip joint and gets his femur neck fractured. Okay, after going to the emergency, his X-ray appears as this. There is a fracture in the neck of femur region. Now, what do you think we should do and what do you think will happen? Okay, there are three scenarios. One is the patient ignoring it. Okay, see, there are three scenarios. One is the patient ignoring it. If the patient ignores it, do you think the fracture will unite by itself? Anyone? What do you think? Will it unite? No, it will not unite. It will go into a non-union, right? Similarly, if the neck of femur fracture is treated by an quack or an unprofessional, or it may, if it has treated conservatively without doing any intervention, just conservatively it is treated, do you think still it can unite? No, still it will not unite. It's a non-union still. And if the patient has come lately for the treatment, has ignored for a few days or 1 or 2 months, then because of persistent pain he has come to you. Okay, now what do you think would have happened to the neck of femur region? The head would have gone, because of the delayed treatment, the head would have gone into avascular necrosis. So this is the sequence. Now can you answer me in the comment, why do you think there is avascular necrosis of the head? We'll learn it sometime in the video, but pause the video and think for it for some time. So for knowing this, we have to go back to the basic anatomy of our femur's head, that is femur's peculiar blood supply. For knowing that why AVN is seen in the femur neck fracture, we need to get back to the anatomy. So let's zoom into our femur neck region. Okay, let's zoom into our femur neck region and we will see it. As you can see, this is our femoral area and its arterial supply. Now tell me one by one, what are these arteries? Now tell me, what is this large artery coming here? This is number 1. I think it's not properly visible. Let me change the color. Yeah, let me use yellow. Yeah, now you tell me, what is this artery? This is number 1. Then this is number 2. Now from here there is a vessel going like this. This is number 3 and another vessel that is going like this. Okay, this is number 4. Now first tell me these 4 and we will go further. So number 1 is this large artery. So number 1 is this large artery is our femoral artery. So this is our femoral artery. From the femoral artery we get an branch that is called as profunda femoris artery. Okay, from the profunda femoris artery in a reverse direction there are two branches coming out. That is, one is over the lateral aspect of the femur, that is called as lateral circumflex artery. Lateral circumflex artery, and another artery that is going towards the medial side. Let me show you once. The medial side, this one is the medial circumflex artery. So there are two arteries coming from our profunda femoris artery, that is the lateral circumflex and the medial circumflex. Okay, those two, they encirculate at the base of the neck region. Okay, and these two form an anastomotic ring. These two form an anastomotic ring at the base of the neck, called as the extracapsular arterial ring. Why do you think it's called extracapsular? So as you can see in the opposite here, see, this is the ligaments and these are the ligaments and the capsule covering the hip joint, and they are covering only till the trochanteric ridge. Okay, they are covering only to the capsule, and the ligaments, they cover till the, mainly the capsule covers till the trochanteric ridge. And this arterial ring, it is at the base of the neck, and it is outside the capsule. Okay, it is outside the capsule. Now from these lateral retinacular and medial circumflex and the lateral circumflex arteries, there are branches going through from on the neck into the capsule in a ascending fashion over the neck, and also in the intraosseous part through the neck. From this it will go into the bone and to the center of the head and over the head, and they again all the branches unite at the just below the head region or the subcapital region. Okay, these ascending branches are called as ascending cervical branches. These are the ascending cervical branches, and at the base of the head, that is the subcapital region, there is another ring which is inside the capsule, and it is called as intracapsular arterial ring. Okay, this is the intracapsular arterial ring, and from this intracapsular arterial ring there are vessels going towards the epiphyseal region or the head region. Okay, and the vessels going towards the lateral side of the head or the epiphysis are called as lateral epiphyseal arteries, and towards the medial side they are called as the medial epiphyseal arteries. Okay, and some part that is left over here, this some part that is left over here is again supplied by the artery coming from the obturator artery. This is the obturator artery that gives an artery to the ligament of teres, and that artery is called as foveal artery. The foveal artery or the artery of ligamentum teres also gives branches towards the head, and this will contribute to the blood supply of the femoral head. Okay, this is the blood supply of the femoral head. Now you understood the blood supply. Now let's understand what happens in neck of femur fracture. Okay. Now for suppose the neck has fractured here. In our example the neck has fractured at the subcapital region. Okay. Now what blood supplies have been cut off? The blood supply from both the lateral and the medial circumflex arteries and the ascending cervical branches, all these blood supply has been cut off. Okay. The only blood supply that is remaining now is our foveal artery, that is giving only less than 20% of the femoral head. Now what do you think? The head can survive with this only 20%? No, the head may not survive with this only 20% of the blood supply. Okay. Now let's see why avascular necrosis is occurring and other most common complication that is occurring before the avascular necrosis. So what are the factors that is responsible for non-union? So non-union is the most common complication that is occurring after the neck of the femur fracture. Okay. Now why does this happen is, one, you have already learned, because of the lack of blood supply. The other reasons that we'll be knowing is the anatomical factors and the mechanical factors. See what the anatomical factors is. First, it is an intracapsular location. Within the capsule, any joint within the capsule, what do you think it will have? It will have synovial fluid. The synovial fluid, it will not allow for the callus formation. Why it does not allow? Please tell me what are the stages of fracture healing? There are 4 stages of fracture healing, right? 4 or 5? There are 5 stages of fracture healing. Number 1 is the stage of hematoma. The stage of hematoma, the stage of granulation tissue. Next, third is stage of soft callus. Fourth is stage of hard callus. Number 5 is stage of remodeling. Right. There are 5 stages in total. Now, what is the first stage? The first stage is the stage of hematoma, right? Now, if synovial fluid is present, it will not allow for the hematoma to get organized. The synovial fluid contains so many enzymes like metalloproteinases and other enzymes that will break down the hematoma. If the hematoma is not persistent, it is not organizing, then it will not go into the stage of granulation tissue. So the first stage itself is getting damaged and it is not progressing into the union. It is the first most reason. Because of the intracapsular location, the synovial fluid will prevent organization of the hematoma. Next, because of the disrupted blood supply, the medial circumflex artery is the major blood supply that will give blood to the femoral head. Okay. Now because of the fracture, medial circumflex artery blood supply has been disrupted. Next, there is no periosteum over the fracture. There is no periosteum over the neck of the femur region. Okay. The other regions like the shaft, it has periosteum. Now, from where does this osteogenic progenitor cells come from? For the stage of soft callus or hard callus. For the stage of soft callus or hard callus to form, it requires osteogenic progenitor cells. Those osteogenic progenitor cells come from the periosteal layer. It has two layers. Periosteum has two layers. One is the cambium layer and the visceral layer. Okay. One is the fibrous tissue layer and the stem cell layer. From the stem cell layer, that is the cambium layer, the osteogenic progenitor cells come and those will form the callus. But as the periosteum is only absent at the neck region, it will have less chances of union. This is the third factor, lack of periosteum. Next, there is a poor cancellous bone contact after the displacement. If the head is displaced, there is no contact. Then absence of the organized hematoma, which is washed away by the synovial fluid. This I have explained in the first point itself, right? Now, because of the mechanical factors, what mechanical factors will be playing here? If you want to understand better, watch my femur neck classification videos, the Gardner's classification and the Powell's classification. In the Powell's classification, I have explained that because of the vertical alignment of the fracture, there are more shearing forces occurring at the neck, and because of the more shearing forces, there is more chances of displacement and the fracture getting displaced and not uniting. Okay, this is the major factor that does not allow union at the neck of the femur fracture. One is there is no adequate reduction or there is a malalignment. Then because of unstable fixation or improper fixation, there is a micromotion at the fracture site. The fracture is not fixed, properly fixed. There is a micromotion at the fracture site. That's why the fracture will not unite. This is the mechanical factor. Because of the high Powell's angle, there is increasing the shearing forces and there is resisting for the union. More the vertical the fracture, more chances of shearing force, more chances of displacement, more chances of non-union, right? These are the factors responsible for the non-union. Now, what are the factors that are responsible for the avascular necrosis of the femoral head? See, there are three main reasons. One is, you have already seen, the vascular disruption. Then presence of the intracapsular area, there is a increased pressure that I will explain, and because of the fracture displacement. First, because of the vascular disruption, the reticular branches, that is the ascending cervical branches of the medial circumflex artery, these are the main supply for the femoral head. Only 20% supplies from the foveal artery, and the lateral circumflex artery will supply 30 to 30%, and remaining nearly 50% of the head is supplied by the medial circumflex artery, right? And intracapsular fracture line cuts off the terminal vessels that enter the head. Okay, these are the terminal vessels entering the head, and this blood supply is cut off because of the fracture. And because of the ligamentum teres artery provides only the minimal backup, there is an insufficient revascularization. Because of the foveal artery or the ligamental teres artery, there is a insufficient revascularization for the femoral head. And because of the intracapsular area, the hematoma or whatever the blood is coming out from the fracture region, it will not escape into the soft tissues. It will build up a tamponade effect inside the capsule area. Okay, in a closed container, a solid container, if you fill up it with some liquid and close the lid and seal it tightly, okay, and try to inject more fluid into the container, what will happen? The container, the solid container will accumulate only whatever the space it will have, and if you try to inject more volume into it, there is an increased pressure within it, and it will try to, the solid container will try to expand. Okay, similar thing happens in the capsule. Till the capsule expands, it can accumulate the hematoma or the fracture fluid, that is the fracture blood coming out. Once the capsule is tightened and there is no space for the capsule, what it will do is, the pressure is sent towards the terminal vessels in the intraosseous region. Okay, within the head, the intraosseous region, the pressure is affected on the intraosseous blood vessels. These intraosseous blood vessels will get compressed because of this tamponade effect. This tamponade effect, the intraosseous vessels will get compressed, and this will lead to the ischemia of the femoral head. Okay, this is the intracapsular pressure rise, and because of the fracture displacement, that is Gordon force and Gordon three types, there is a complete vascular disruption. And vertical power, similarly, the greater vessel stretch will be there, and there is greater vessel rupture. This will also lead to avascular necrosis. Now, what are the major differences between the AVN and the non-union? When do you think non-union will occur in the femur neck, and when do you think avascular necrosis will occur? I have told you non-union is the most common, but when does avascular necrosis will occur? Now we will see the differences, when will AVN occur and when will non-union occur, and what are the different causes for these two. Okay, so the primary cause for non-union is fracture healing process is failed because of the washing away of the hematoma, no periosteum, less cancellous bone contact. These are all the fracture healing process is not allowed. This is the primary cause for non-union. But interruption of the blood supply and the bone becoming dead is the main cause for AVN. The level of the problem in the non-union is at the fracture line. Okay, both mechanical and biological failure occurring at the fracture line. But the level of the problem in the avascular necrosis at the femoral head, that is ischemic necrosis of the femoral head. And the timing of presentation, this is the most important. When do you think non-union occurs? The non-union is the earlier complication, okay, because of delayed healing or lack of union at the. Can you tell me, when do you call non-union in femur neck fracture? I have asked this question in the last video. When do you call non-union in femur neck fracture? Because the FDA approved definition for non-union is 3 months in femur neck fracture. In femur neck fracture, 3 months is the duration. Beyond 3 months, if the neck of the femur is not united, then it's a non-union of neck of femur. Okay. Beyond that, months after the fixation or months getting delayed, the presenting factor is the AVN. Lately, the femoral head will get ischemia. Even after fixation or the trauma, the time of presentation for AVN is late. The main factors for non-union is, one is poor stability, lack of callus, poor biology, and shearing stress, that is the vertical fracture line. The main factors for AVN is vascular injury, delayed fixation, and the intracapsular pressure or the tamponade effect. Then the radiological findings that are seen in non-union and X-ray the non-union and avascular necrosis is, in non-union the fracture line will be persistent, the margins of the fracture line will be sclerosed and smoothened. The fresh fracture will have sharp edges, but the lately non-union will have smooth edges, and there is no bridging callus between the fracture. Okay, but in avascular necrosis, what happens is, because of the damage or the bone death, the head becomes flattened. Okay, the weight bearing portion of the head becomes flattened, and the head will have sclerosis and crescent sign. What is sclerosis? Sclerosis is whitening of the femoral, the bony region, because of death or necrosis. What happens is, bone is a living organ. Okay, continuously there is an exchange of calcium minerals into the bone and outside the bone. There is exchange of minerals. Once the bone gets dead, whatever the calcium within the bone is left over within the dead bone, and it cannot be brought back into the regular circulation. So the leftover calcium in the bone will appear as whitish area in the X-ray. Those areas are called as sclerotic areas. Okay, within the head there is sclerotic areas, and there is a crescent sign. What is crescent sign? Crescent sign is half moon shape appearance. Half moon shape appearance of the femoral head in the subchondral region, just below the cartilage of the femoral head. In the subchondral region, we will find a thin rim of sclerotic and lucent area covered. Within the sclerotic area, there is a lucent area of crescent shape. This is called as crescent sign in avascular necrosis. We will discuss the avascular necrosis classifications in detail and what are the other causes for the AVN in femoral head avascular necrosis, or in other terms osteonecrosis of femoral head. This will be discussed in a later video. Okay. Now, what is the outcome of the non-union? The outcome of non-union is there will be an instability. The patient will not be able to bear weight because of instability. There is a continuous instability. What gait will occur in instability of femur neck? This is an homework for you. You comment in the comment section. We will discuss it in the next video. You comment it, what type of gait the patient will have when a femur neck non-union has happened. Okay. And the outcome of avascular necrosis is the joint get destroyed, that is osteoarthritis will occur of the hip joint. What is the treatment, final treatment for non-union? We have to revise the fixation, or we have to do an valgus osteotomy neck. This valgus osteotomy I will be discussing in detail in non-union neck treatment. Okay. And what is the treatment of AVN? We do an joint replacement, that is arthroplasty. This is the journal of World Orthopaedics Journal. In this journal, they have nicely given an X-ray from the time of fracture till the non-union and AVN. So, initially there is a neck of femur fracture, and later after few months the edges are getting smoothened. Then later the femoral head starts getting sclerotic appearance and it has lucent areas within. The edges are still getting smoothened out and the neck is slowly getting resorpted. Okay. Here almost the neck around the head region has resorpted and the head is showing sclerotic regions, and there is a crescent sign just below the femoral head. Okay. This is both non-union at the neck of femur region along with AVN of the femoral head. Okay. So thank you guys. Thank you doctors. Please like, share and subscribe to Asan Network for more interesting videos. Stay updated and stay confident in your clinical rounds. Thank you.